Good afternoon, everybody. This is an extraordinary time and an extraordinary event, and we're here to announce an extraordinary event. First of all, my name is Mike Dowling. I was the co-chairman of the Medicaid Redesign Team, along with Dennis Rivera. And as you do know, the Medicaid Redesign Team began on January 7th. And we went through a different and unique process in the state, where we went through whole public hearings all over the state, got all of the various stakeholders from all parts of the healthcare system to get involved, held long public hearings, got lots of suggestions, well over 4,000 suggestions about what to do with the Medicaid program, because obviously the ultimate goal and the original task of the task force was to get savings and hit a savings target, as well as restructure and redefine the Medicaid program so it can be sustainable long term, because everybody recognizes the benefits of the Medicaid program. We just got to make sure it's sustainable and affordable, and that's what we attempted to do. We also got lots of suggestions from the web, through the web, and we were very, very fortunate to have the Medicaid Redesign Team, the members of whom are behind me here, from all components of the healthcare enterprise, all coming together in a collaborative, cooperative way. And we had a long meeting today, all day, and we had the proposal, which will be discussed with you in a few minutes in a little bit more detail, actually hits the target that was laid out at the very beginning, the Medicaid target, and puts a cap on global spending on Medicaid going into 11 and 12, as well as make substantial reforms in the Medicaid program, which is a unique collaboration and compromise of cost savings and reform. And I am very privileged to have the opportunity to be the co-chair, and very privileged to work with all of the people behind me here. I thank Governor Cuomo for the leadership on this issue, which is very, very important to the state of New York and obviously to the state budget. What I would like to do is, at this moment, is to give him something to read, which is the actual report that we voted on today. So the task force today voted on the package, which includes the cost savings, a global cap on Medicaid, hitting the budget targets for next year, as well as substantial reforms in the Medicaid program. And they're all in here, and I would very much like to hand this to the governor to say thank you for the opportunity. And when you go home tonight, you can spend your time reading this.
Thank you very much. Thank you. Thank you. Thank you. Well done.
And again, I don't think we can underestimate the extraordinary nature of everybody coming together to produce this in a very, very short period of time that has real substantive changes in it. And it's my pleasure at the moment to introduce Jason Helgerson, whom I believe you all know, who is the Medicaid director and who has been very instrumental, along with Jim Introne and all the staff at the health department, in helping us through this process. And so, Jason, you can spend a few moments explaining a little bit of what's in the proposal. Thanks.
Well, thank you, Michael. It is very exciting to be here today. Tremendous amount of work has gone into this project. The team behind me has invested many hours, not only in substantive meetings, but also in hearings all across the state. 5 hearings were held for many hours of testimony. We heard from New Yorkers from every corner of the state affected by the program in a myriad of ways. We gathered over 4,000 proposals through this process, and it really was about a month and a half of work time. So it's an incredible amount of effort went into what I firmly believe is a very comprehensive package that not only hits a budgetary target, but really does move the bar up in terms of substantive reforms of this very important program that serves 4.7 million New Yorkers. And in terms of some of the specifics, as was mentioned, the proposal includes a global cap. First time a global cap has been enacted in the state, or would be enacted in the state of New York. That cap applies to the state share of the program, which is $15.109 billion. In addition to that, it does give the state Department of Health flexibility to help enforce the cap, but the hope is, and that's why I think what makes this package so innovative, so exciting, is that you have the healthcare community coming together for the first time to say, instead of the old-fashioned across-the-board rate reductions, give us the opportunity, give us a window of time with which we can work together to address issues that drive costs and lead to poor outcomes for the 4.7 million New Yorkers on the program. And the goodwill that has been generated through this process and the opportunities under this global cap to generate collaboration and cooperation, I think, is particularly exciting. In addition to the cap, a couple other major initiatives included in the package. As a result of this initiative, 1 million New Yorkers who are enrolled in the Medicaid program will now have access to patient-centered medical homes, including some of the most complex and highest-cost people. Those are dual eligibles, people on Medicare and Medicaid. We're going to really make a major move in terms of expanding access to high-quality managed care and care management. Within 3 years, the entire population of the Medicaid program in New York will actually be in some form of care management. That is a fundamental shift in how this program exists, the idea of the fee-for-service, uncontrolled, uncoordinated program sort of ceasing to exist in a short period of time. Also, it introduces substantive quality and cost controls in areas that have been highlighted as problematic, particularly personal care and home care. A lot of work went on between a wide array of stakeholders on these very complex issues. They've been tried in the past, but really have failed, and I think the team worked tremendously well together on that. Not to be lost, significant reform of the medical malpractice laws in our state. Medical malpractice reform, as we heard loud and clear as we traveled the state, is a Medicaid problem. 50% of all the children who are born in the state of Wisconsin, or in the state of New York, excuse me. It's the first time I've actually done that in a while. In the state of New York are on Medicaid. And so as a result, when there are exorbitant costs in medical malpractice insurance, those costs, in essence, get passed on to the Medicaid program, and there's some substantial opportunities as a result of those packages. And finally, I think a lot of times what's lost with Medicaid is that it is, as the governor has so articulately stated, a series of rules and regulations that are complex and oftentimes work at cross purposes. And we heard, as we traveled the state, over and over again, examples of crazy rules, regulations, formulas that are embedded into the law that make it more expensive, more difficult for providers as well as for members to navigate the program. And there are substantive examples in here of efforts to really streamline and eliminate those unnecessary regulations. So very excited to have this comprehensive package. So with that, I'd like to turn it over to George Gresham.
Thank you, Jason. First of all, I'd like to officially put to bed the rumor that I was going to resign from the Medicaid Redesign Team. But I want to say, you don't challenge the kind of budget deficit that we had without dealing with pain. And this certainly, as it will reflect, resulted in pain. But it was shared pain. And I want to thank the governor, one, for the opportunity to allow working people to be a part of the solution so that we can work together and create ideas. And I think that one of the beauties that come out of this is that we're not only going to have a more efficient system, but a system that can produce better outcomes. And for us in the healthcare field, that's really what matters. This really wasn't just a matter of balancing budgets. This was a matter of making sure that the purpose of Medicaid, for which it originally started, gets satisfied in a way that is sustainable, in a way that continues to provide the care. Me personally, sitting in those community hearings to hear people come and basically say to us, please save Medicaid. Please make it a way that the state can afford it and that I can still have it so I have a decent quality of health. That could not have happened if we just chose to battle each other on numbers. But because we began to set an example, and I hope an example that is spread throughout this country, that working people are not the problem, but working people can be a part of the solution. I thank the governor for that opportunity, and I thank the Medicaid Redesign Team for that. And we're happy to say, let's go forward and continue to build New York and make it a better state. Thank you.
Thank you, George. I'm Ken Raske, president of the Greater New York Hospital Association. And today is a historic day by any stretch of the imagination. Jason outlined the essence, basically, of the proposals. It is a hard and very real cap. The first time that I'm aware of that has been done anywhere in the United States. That is going to be a trendsetter, in my opinion, in the future of healthcare. But within that cap are tools that are being recommended by the task force to try to help increase the efficiency of the healthcare community. They're wonderful recommendations for the most part, and very practical recommendations. And the bottom line is, as George Gresham indicated, is really to make sure that with limited resources, we get the most efficient Medicaid program that we could possibly get that produces the best quality product for the people of the state of New York. Now, a personal reflection from me, many of you know that George and I particularly have been combatants in this arena for many, many years. And we didn't like it, and I can tell you that honestly. Our governor has given us an opportunity to work together, to fashion proposals that are good for the people, and not to take the issue to the court of public opinion as we have in the past. But I submit that this is a much better way for all concerned. Governor, I want to thank you personally. Sir?
Well, thank you. This is, I'm excited. This is probably one of the most productive days since I've had the honor of serving as governor of the state of New York. This was a unique undertaking that this commission set out to do, and a truly difficult one at that. The mission was to balance the Medicaid budget in probably one of the worst economic circumstances that the state has seen in modern political history, to live within the budget numbers that we had set out in the budget, which were very aggressive, and as Mr. Gresham said, not just to reduce the cost, but actually find a way to make the program work better, to serve people better, right? Reduce the cost, but actually serve people better. And to do all of this in 27 minutes. And that was the mission. And people said, well, this will never happen. It will never be done. It's too difficult. They're too contentious a group. Ken Raske's point, I don't know if anyone remembers, in past years, $11.99 in Greater New York would run a couple of TV ads just about this time of year. You probably never noticed. Governors in the past noticed, I can promise you that. But can we get this group of people, bring them together, task them with this very difficult mission, this very aggressive time frame, and get it done? And lo and behold, they did. And they did, frankly, ahead of schedule. I said when they were debriefing me, I said, in Albany, you actually meet a deadline. That hasn't happened in decades. And to get done before the deadline, I think that's probably an historic first in this room. But they accomplished the task. They accomplished it ahead of schedule. And it really was an extraordinary undertaking institutionally, the number of meetings, the number of proposals they had, but it was also a personal triumph. This is a group of people that not only spent a tremendous number of hours working on behalf of the people of this state, but they respected their own profession and their own industry, but they also respected their role as New Yorkers and as healthcare providers and professionals within healthcare. And they got beyond themselves in many ways. I'm honored to have been part of it as the governor of the state. We now have to take the proposal, which matches the expectations that I created in the budget. We send it to the legislature, and we say to the Assembly, and we say to the Senate, pass this budget. Pass this budget. To the extent we've heard over the past few weeks, well, we don't know if the Medicaid team is going to work out. There are blanks in the budget, the cynics and the pessimist said. Well, we just filled in the blank, okay? The questions have been answered. Now we need the legislature to fill in the blank and to do their job and to get a budget passed on time for the people of the state of New York. To Michael Dowling and Dennis Rivera, who had to go back to Puerto Rico for a personal emergency, but they were the co-chairs of the committee. Tremendous, tremendous effort that they made, and I thank them personally for their time and on behalf of the state. Ken Raske and George Gresham, who you heard from today, who were extraordinary in this. And this will be an ongoing effort, right? There'll be a working group. There's still more to do to implement. I don't want you to think you're all getting off with just today. We still have some more work to do. But I want to thank them and all the members of the commission. Really, the people of the state of New York owe you a tremendous debt of gratitude, and I want to express that as governor of the state. Thank you very much. Michael, Ken, George, why don't you join me up here, Jason, for any questions, comments?
Mr. Helgerson and Mr. Dowling, in a process that's been so devoted to transparency and openness, why schedule a second day of hearings or for your meeting and not go through with it, which was a decision that clearly left some members of the panel feeling rather bruised?
We started this when we planned this initially, given the extent of the large list of proposals and issues. We said, just to be safe, let's put a second day on the schedule in case we need to go over into the second day. It became very, very clear to the members of the redesign team today, as we were going through the proposals, that we would be able to get through them all and with a high degree of substance and detail by the end of the day today. So rather than just having everybody, hang on to do another day, which would not necessarily add anything substantive to the actual proposals that were being discussed, I asked that we call for a vote by the members, and as you can see, it was by the vast majority agreed with the proposal to submit the recommendations today to the governor and to move forward with the preparation of the legislation and move forward with the legislative discussions, etc. That was the reason.
You mentioned that all parts of the healthcare system were involved.
Yes.
But who was here representing the independent pharmacies? They're part of the healthcare system, aren't they?
Yes, we remember throughout the process of the hearings, the public hearings, the individual discussions with all of the individual members out there. There were discussions with absolutely everybody. So there was nobody on the table from the independent pharmacy, but that does not mean that the independent pharmacies did not have their opportunity to have input.
Was there a particular reason why the independent pharmacies were not in the team?
I just suggest say what I just said already. They had opportunity to have input. Issues were discussed openly and frankly, and the team was put together as the team, and that was the team that we moved forward with.
Have you discussed this at all with the legislative leaders or any input at this point along the way, and how much latitude would there be in negotiations from this point forward?
You have, Michael, 2 members of the Senate who are on the task force. You have 2 members of the Assembly who are on the task force. I believe 3 out of 4 are here today. They have been, first of all, this was an exhaustive process, and I want to thank the Assemblymen and the Senators for participating in it. They were available for all the meetings. They went through all the proposals and all the discussions. So the Assembly and the Senate have been part of the process all throughout it. The Assemblymen and the Senators did not vote today on the proposals because they're going to vote at a different time when they vote on the entire budget. And this package will be presented now to the Assembly and the Senate. So they have been briefed all along the process because they have been part of the process. From my point of view, I presented a budget with numbers and targets. And the question was, how will you hit those targets? That's what this report now answers. What does the legislature do? You know as well as I know what the legislature does. We'll see. I know they've been briefed. I know they've been advised. I know that I have done what I said I was going to do. I know the committee did what it said it was going to try to do, and they were successful. This will be now part of the budget submission to the Assembly and the Senate, and we'll see what they do.
Governor, Kyle Hughes here. My question is, people that have private insurance, most of them are in HMOs and managed care. Will managed care under this agreement for Medicaid recipients, will it be on par with the same kind of managed care that people with private insurance? And I'm thinking, for example, of formularies. Is there going to be a formulary under this plan that can cover prescription drug costs for Medicaid?
Yeah, I believe the answer Kyle, is yes, but I'm going to ask Jason to answer the question. Just if I could quickly get back to Mike. What I would hope the legislature does is take this report and pass the budget, and pass it within the time set by the law, right? What I said when I was first elected, let's try to make the government work for the people. Let's try to bring function back to Albany. There is a deadline. It's called April 1. It's not just a date. It's a deadline. It means something. Pass the budget by the April 1 deadline. Pass a budget that represents the people of this state. I think this budget does that. Do I have flexibility, and do I understand that it's a dialogue and a back and forth process? I sure do. But I also understand the legal responsibility of the governor of the state in the budget process. It is an executive budget. And I believe the budget that they have received has been questioned, has been discussed. And I think especially with today, what you see is the budget as a comprehensive document and a realistic document as presented is, if anything, getting stronger the more you look at it. Jason, would you like to respond to this?
Sure. The answer is actually that we do contract with a wide array of managed care organizations, and the plan envisions actually potentially new organizations coming into the program as well. But I think a real success story here in New York, and I think why we are so excited about the possibility of more managed care expansion, is that when you look at the performance of our current managed care partners, is that in the case of the Medicaid population and also in the commercial, their performance actually exceeds national norms. And so I think that we have an excellent platform to build upon, and look forward to more partners in that area as well.
Does this plan include an expansion of the HIPAA surcharge?
It includes a expansion for certain codes in certain areas for certain providers, but it's a modest expansion, yes. Yes, that's correct.
Does that, in your mind, does that constitute cost control or reform with Medicaid, or is that just raising money?
That's an excellent question. The proposal here is, in our view, an equity issue, is that basically what we're trying to do is have the HICRA surcharge, in essence, keep up with the delivery of health care. As I think we all know, healthcare is an ever-evolving business, and what we're seeing is more and more services provided not in an institutional environment, but more in an office environment. And so what this does is attempts to ensure that there's equity between providers in institutional environments and providers in non-institutional environments. Sure. To get to to get to 2.3, which is the revised target that the governor laid out, there are several parts or proposals, or in essence mechanisms for getting there. The first and largest is the reform package that was put forward. That's roughly $1.138 billion. In addition to that, we are eliminating statutory cost drivers, sometimes referred to as sort of indexed rate increases, both on the managed care and fee-for-service side. That's $186 million. In addition, we have strived very hard in this process to avoid across-the-board reductions, but given the challenges that we face, we do have what we think is a fairly modest 2% across-the-board reduction that generates $345 million. In addition to that, we've identified a couple of areas where we can maximize the value of the enhanced federal funding that we're in right now, and that generates a net of actually about $70 million. And then finally, the last piece is, in essence, an industry-led cost containment initiative, which is, in essence, what really came out of the industry as part of the CAP discussion. I think, and I can have Ken talk about it as well, but I think when we put out that list of 49 proposals, there were a number of proposals in there that were old proposals, things that had been brought up in years past that were really just large reductions to various elements of the healthcare industry. And what the industry said to us was, give us an opportunity to find savings. Don't hit us with further across-the-board rate cuts, and we'll live under a cap, but understanding that if those savings don't materialize, that the Department of Health would have the flexibility to enforce the cap. And so I don't know, Ken, if you want to.
Well, sir, absolutely. The proposal is that in the submitted budget, the gross amount of funds is $52.8 billion. That's with federal share, state share, and so forth. And this proposal that has been adopted by the task force puts a lid on it. It cannot be $52.8 billion plus one. That is a steadfast cap. And it would be triggered by monitoring on a monthly basis, or however how the budget people decide to monitor it. And if in fact it starts going over, or looks like it might be going over, then enforcement devices will be fashioned and will be put in place. This has never been done before.
So how much does that work, Ken, as far as
640.
Well, depending in terms of the budget, it would about $640 million in terms of reductions that would constitute risk. Okay.
Also, just to be, excuse me one second, Mark, just to be clear on the process, this plan will be presented to the legislature as within the 30-day amendment window. So it will be an amendment to the budget that was submitted within the statutory time frame. And this commission, Mr. Raske speaking on behalf of the hospitals, Mr. Gresham speaking on behalf of 1199, et al., will be supporting this plan's adoption by the Assembly and the Senate. I'm sorry, Mark.
Sure.
This is a pharmacy-centric line of questioning.
It is very much so. I noticed that, yeah.
Okay, check it.
That's
I don't
good.
know that they do that in Wisconsin.
That's good. That's a level of detail that I'm not used to. Yes, there are a number of pharmacy proposals contained in the package. One of them is an optional mail order pharmacy proposal. The idea is that for people on maintenance medications or for people who need specialty drugs, mail order and can be superior. It can be coupled with care management strategies for people with complex healthcare conditions. So we think it has merit for certain subsets of the population.
What was the vote today?
Mike, you want to?
The vote was three people, members of the legislature abstained. And we had,
And Laura Castle.
and one other person abstained. And other than that, it was unanimous.
And how many members are missing today?
Two.
How many is on the full committee?
27.
27.
So there was 25, and we had 4 people today abstain, so it was 21 yes, unanimous yes.
When did you raise the idea to have a vote today? Was it during the lunch break, or when did that come up?
That came up in the middle of the meeting today, and it was discussed when we had a break during lunch, and members indicated that we had a lot of time to deliberate. There were some issues. There are some language issues and some part of the pieces of the recommendations that can be worked on over the next number of weeks, but it didn't serve any purpose to belabor the issue and just continue just for the sake of continuing. It's also important that if you have a deadline, it's always good to beat the deadline. You just don't have to go walk up to the deadline just because you have a deadline. I mean, that's why you put deadlines, is people can meet the deadline before the deadline. Am I making that too confusing? Yes. Okay.
Perfectly clear.
Okay. Thank you. There
All
were,
legislators.
yeah, all
Well,
4 leg.
actually, I'm sorry.
One was missing.
There were 3, right, there were 3 not present, okay, and there were 4 people abstained.
Same, right.
I don't believe, Liz, the abstentions by the legislators shouldn't be read as a hostile act. The agreement was that they wouldn't be voting on the package because it was going to be presented to the Assembly and the Senate.
And
Mike Amen, you would say, it seems like more than a quarter of the savings you guys are proposing here is in this industry-led cost containment, and that's still a big blank. I mean, you talk to hospitals today and they have no idea how they're going to do this. So if you have a quarter of, it still seems like there's a large, blank here in this plan. And are there any ideas yet?
Oh, there's plenty of ideas. The thing that you have to really compute here is that this is a hard cap. So what this will do to the healthcare community, this goes beyond hospitals, includes my colleagues in nursing homes, home health care, and beyond, is that the industry has to live within it, come up with ways to become more efficient, singularly and collectively. Otherwise, they're going to get a cut. I mean, that's it. This is a loaded weapon.
But how much time does it take, a year, each year you commit that, or you have to
Well, I mean, the 52.8 is set for this year, although this is a multiple-year plan.
Dude, why don't you just say what a patient-centered medical home is? Apparently a million people are going to be in it. I've never heard of it.
Sure. Patient-centered medical home.
They're run by the pharmacy industry.
Yes.
It's a mail order program.
Patient-centered actually, New York is a national leader in this area, and basically the idea is that there are various ways one can define it, but there are a couple of nationwide organizations that actually set criteria for them. But the basic concept is that you have a primary care provider who has certain tools, who really is sort of responsible for helping to coordinate the healthcare needs of a particular person or a particular family. The idea is that healthcare really should be a team sport, not an individualized undertaking, and that what patient-centered medical homes do is they help to try to bring providers together, specialists, nurses, nurse practitioners, physicians, together to really work together for the comprehensive needs of that population. If you really want a good example, No. This is patient-centered medical homes are really for acute ambulatory care services, but it can transcend beyond that to other settings. I would actually direct you, if you want a great example, is there's a national model program that's being built and working in Adirondack that's fabulous, and I think that would be a great way to really understand it, is to actually see one in operation.
no, it's not a facility.
It's not a
This is
facility. No.
It's really electronic health records and all the consolidation.
Yeah, it's really a provider who working in coordination with other providers. And the reason why it's used as a home, which is that you have a patient has a place to go when they need healthcare services, and there's somebody out there looking out for their needs and interests, and making sure that all of the providers that are trying to meet the needs of that single person are in communication, electronic communication, on regular communication, working together to meet the comprehensive needs of
So this is intended so people don't go to emergency rooms in hospitals.
Absolutely. Those are key outcomes.
Yes.
I mean, the biggest challenge that New York has, or one of the biggest challenges that New York has, is that we have far too many people going into hospitals and other institutional settings. They should be out. They should be, we lead or nearly lead the nation in unnecessary hospital admissions. And if medical homes can help to be a solution to that.
Are you simply saying that everyone on Medicaid is going to have a primary care doctor? I mean, is that what that is?
The idea is that within 3 years, everyone in the Medicaid program, or virtually everyone in the Medicaid program, will be in some form of care management, meaning that there'll be somebody who's actually contractually responsible for making sure that the comprehensive needs of that person are met and that the services are coordinated. That is why this is such a big deal proposal.
This redesign team is going to continue existing? What's its next task? Well, first, on the questions of the schedule, remember the task force had to be done by March 1, but the work of the task force has to be converted into legislation, and that had to be done by the 30-day amendment period. So Mr. Dowling's point is right. If you concluded your work, don't continue meeting just to meet. I don't think we paid you by the meetings, did we? So they finished their work. There was no point in meeting once you completed your work. And there's now a lot of work to take this report and actually turn it into legislation in time for the 30-day amendment. The official work of the MRT is over, Bill. It was tasked with a specific task. It has performed that admirably well. There will be an ongoing working group to make sure this is facilitated, and I'm sure from an operational level, not a legislative level, but an operational level with the Department of Health, you'll have issues from time to time, and we'll have a working team together that can address them. But this was, let me close where I began. This was a very, very ambitious undertaking. Many people in this room expressed skepticism that it was possible to finish. Some days, frankly, I had my own doubts. But it was really a function of some really special people and fantastic professionals who made it work. And again, we owe them a tremendous debt of gratitude. Let's give them a round of applause, and I thank them very much for their service. You want to take a question? Please. Thank you. You know, I think, Fred, thank you very much. No, that's okay, thank you. I think that a better system than last in, first out seniority-based system is a system that is based on merit, which means you then need an objective evaluation system to actually determine that merit. We don't have that system in place in the state yet. Depending on who you talk to, you get different estimates of when we will. That is a system I think we need in any event. My presentation on the budget when it came to education funding, a major priority for me is performance funding, performance standards, which means you're going to have to be able to evaluate that performance. And this would be one such example. So we need an objective evaluation system for teachers. If you have that, that should provide at least part of the basis for making a determination. I think what happened is, when you have no objective evaluation system, what do you use? Well, then use just seniority, because you have nothing else. And that's really what the LIFO system is, seniority when you have nothing else. But we should have objective evaluation criteria.
Follow-up, though, do you think the bill meets that test, and were you surprised at all by the 85% figure that came out of the poll, favoring the alternative?
You know, I didn't think about it before, Fred, but I don't know that it was surprising. If you ask people, you have to make difficult decisions on who should stay and who should go. Should they be based just on seniority, or should you consider performance? I think the answer is performance.
And the bill itself, are you familiar enough with it to say whether it meets the criteria, the test that you'll apply?
I am not. I haven't reviewed the bill. I don't know that it really sets up an objective evaluation system, which is what I think you're going to need as a meaningful alternative to a LIFO system. I just haven't read the bill.
Governor, the Senate Democrats claim that Republicans are using a procedural trick to prevent their members from signing on as co-sponsors to the redistricting bill. Do you have any reaction to this? Do you think that Leader Skelos is acting in bad faith by using this tactic?
You know, I just don't know. I've heard the charge. I just don't know. So I can't say, I don't have an opinion on whether the Senate Democrats are right or wrong. I do know that this is a bill that I think is vitally important for the state of New York. We have talked about this for many, many years, but this really is a bill that can make all the difference. I presented my ideas. I spoke to it often and aggressively through the campaign, and I will continue to do so. You know, one of the common stories in Albany, Michael Dowling, who was here, I worked with many, many years ago. He was in my father's administration. He now runs North Shore. He's one of the preeminent healthcare professionals in the nation. But he was kidding inside. He said, you know, deadlines used to be deadlines, and things used to happen. Independent redistricting is one of those things that we just talk about ad infinitum. You know, every year we talk about this is what we should do. We should pass ethics reform. We should have independent redistricting. We should pass a budget on time. I don't know that we even believe anymore that it's actually possible. It's not just supposed to be something you talk about, it's something you're supposed to actually achieve. So I think it's vital, not that we just talk about it, but we actually achieve it. And that deadlines are deadlines. And that these bills actually get executed during the course of the year.
What do you believe is the deadline for redistricting reform to take place before the process actually has to get rolling?
Well, I want to see this bill passed.
But by when?
Well, as soon as possible.
Chairman, you have a lot of friends over the years, like Mr. Dowling and all. What personal measures do you take to assure that someone who's, say, serving on a task force or serving in some other way officially doesn't have undue influence on you, or that you don't talk about these things? What do you do?
Well, Mike, I start with the law. I follow the law. That's what I do. And on an advisory board, for example, you follow the law and the requirements for people who serve on an advisory board. On an advisory board, you don't have, for example, client disclosure. Well, why not? Well, because then it'd be harder to get people to serve on an advisory board. Serve on a commission, if you take a job, you're a public officer, then you do client disclosure. So you follow the law.
But if you have a very close friend who's serving on this and is representing a major element of the industry, in the healthcare industry, do you do anything besides what the letter of the law is to make sure that there's no undue influence? Something to assure the public that nothing's happening like that?
Well, this was an advisory task force that was coming up with ideas, speaking to the public. It was run by Jason and Jim, who are public officials. It was chaired by Mr. Dowling and Mr. Rivera, but it was run by Jason and Jim, who are public officials, who are subject to the public officers law. I really didn't participate in the conversations on the commission, so I didn't weigh in really one way or the other on the, or wasn't in the room to hear one set of ideas versus another.
I'm sorry, Governor, I may not be quick. I'm more interested in the element of, if you have a friend, somebody you've been working with for a long time, someone's an associate or friend, how do you know that that relationship doesn't spill over?
To whom? To me?
Sure.
If I have a friend, I take friends' advice, plus or minus, with a grain of salt. If they're a friend, I know where they're coming from, I know who they are, I know their bias, I know their perspective. You know, you talk to someone, you know who they are, and everyone has a perspective. Reporters have a perspective, private citizens have a perspective, and you take that into consideration.
Governor, are you continuing to talk to legislative leaders about other aspects of ethics reform, client disclosure? Do you think you're going to have a bill before the budget is passed? Do you think you're going to have a bill in the next month?
Michael, there are two aspects, two immediate aspects to ethics. There are several components. Campaign finance is part of ethics. You could argue independent redistricting is part of ethics. The two parts that we're focusing on right now in ethics legislation specifically, one is disclosure of clients, and two is an independent commission to do policing. And they're two different concepts. I believe both are vitally important. I believe disclosure is vitally important. Why? It's important to know who the legislators work for. I work for the people of the state of New York. They pay me. They are the only people who pay me. The only financial relationship I have is with the people of the state of New York. Who do the legislators work for? Well, they work for the people, obviously. They're elected by the people. I know, but they're part-time. Who else do they work for? And do they represent anyone before the state? And if they do, under what circumstances and who? I think the people have a right to know that. I believe the people have a right to know that in the absolute sense. I think it's especially acute today when people look at Albany and say, I don't trust Albany, and I don't trust the government. And there have been a series of scandals and a series of episodes that have grown the distrust. So I need to be reassured, and I need to have confidence in the government. I'm trying to instill confidence in the government. Why? Because I believe in the government as a vehicle. And if the government vehicle is going to be effective, you have to have confidence. Because if people don't believe in the institution is impotent. So we have to restore the trust. And saying to the people of the state, this is who I work for. I'm represented, I work for a law firm, these are the clients, these are the conditions, these are the circumstances, here it is. I think that's very helpful. That's number one. Second is the independent policing mechanism, which is just what it sounds like. I said in the campaign many times that self-policing is an oxymoron. And I believe in an independent monitoring mechanism. Those are two separate components. We have them now combined in discussions. You could also separate them in discussions, but both are vitally important.
Are you going to get closer?
We're getting closer. I said on Fred's show. That's sort of, talk about the Albanyisms. That's an Albanyism. We're getting closer. We're getting closer. They are masters at getting right up to the goal line and tiptoeing. I actually saw this in a football game a few weeks back. It reminded me of Albany. Trying to stop the ball from getting in the end zone and making ballerina-like movements, running along the goal line to make sure the ball didn't get into the end zone. So they're very good at making progress up to the goal line. I'm a functional linear person, and success is getting over the goal line. So are we making progress? Yes. Are we talking? Yes. Are those positive signs? Yes. Are we getting closer to the goal line? Yes. Have we gotten over the goal line? No. Is it fundamentally relevant until we get over the goal line? In my opinion, no. I don't put a high value in, well, you had a productive process, except it didn't conclude. Thank you, guys. Thanks very much.